So good morning again. So it is really my honor to introduce to you the Mason Lecture. This is a tradition that we have had in the ASMBS in honor of the founder of the American Society for Bariatric Surgery, now our ASMBS, Dr. Ed Mason. Again, it is an honor to introduce Dr. Bruce Wolfe. Dr. Bruce Wolfe is the professor of surgery and vice chair of research of the Division of General Surgery at Oregon Health and Science University. He is one of our past presidents of the ASMBS. He is a recipient of multiple NIH grants for research. He is right now an investigator of the LABS project, which is already producing remarkable results. He has more than 160 peer-reviewed publications. And he actually was appointed by the NHLBI and NIDDK panel to revise the 1998 NIH guidelines on the treatment of obesity. This panel was organized and started the process of review back in 2008. So that's 5 years ago. He was the only surgeon appointed to this 16-member panel. So the factor which have taken 5 years to accomplish this publication of the guidelines will be discussed. And so it is an honor for me to introduce Dr. Bruce Wolfe.
Thank you very much. It's a great honor to be the Mason Lecturer. Before we begin, I'd like to say just a few words about Dr. Mason, who I had an opportunity to speak with very recently. In the late 60s, he identified the benefits of weight loss as achieved by intestinal bypass surgery, but also identified the unacceptable complication rates and went on to develop the gastric bypass. He was instrumental in some of the early NIH consensus conferences that I will discuss. And to give you an idea of the breadth and scope of his work, he identified the importance of GLP-1 in gastric bypass and its importance more than 20 years ago. And so when we start hearing all about the recent revelations in GLP-1, we just need to go back to Dr. Mason's work and know that we've been catching up with Dr. Mason for many years. I'm going to talk about bariatric surgery and the NIH this morning. I believe this is timely and worthwhile information. I do ask that you not blame the messenger for some of what I have to say. The mission of the NIH is to conduct or support basic clinical translational medical research, to facilitate the dissemination of the knowledge that is learned and the training of scientists. Federal funding of research dates back to 1887 when a research lab was founded. The early research was focused on communicable diseases. The Public Health Service was established in 1912. The Bethesda campus was begun in 1940, and it was in 1948 that Congress officially designated the National Institutes of Health. The NIH supports bariatric surgery research as a component of its obesity research funding, which as of the present time is $839 million per year, much of it devoted to basic research regarding the mechanisms by which bariatric and metabolic surgery work. The LABS consortium mentioned by Dr. Ponce is a multi-center consortium that was funded 9 years ago and hopefully will continue to make important contributions into the future. They've also funded multiple clinical trials. The NIH Consensus Conference program is designed to evaluate scientific information and develop a statement, which is made on the basis of the evidence presented at the conference. And the statements are made which are intended to advance understanding of the subject and be useful to health professionals and the public at large. The first such conference was in 1977 and was devoted to mammography. The most recent, this year, was devoted to diagnosing gestational diabetes, which is an ongoing controversy within that field. The first consensus conference on the surgical treatment of morbid obesity occurred in 1978. Key players in stimulating that conference to occur and its conduct included Dr. Mason, other early presidents of our society, including John Halverson, Pat O'Neill, and John Crowell, and many others who time doesn't permit me to recognize. That conference in 1978 recognized that jejunal ileal bypass was effective in achieving weight loss, comorbidity response, and improving quality of life, but complications were identified to be problematic. The conference in 1978 determined that there was insufficient data available to declare what the place of gastric bypass or gastroplasty should be, other than to say that it was already apparent that complications can be diminished if these procedures are done as opposed to intestinal bypass. The next consensus conference occurred in 1985. That conference was devoted to the global subject of obesity, where the obesity pathology was detailed. That was the focus of the conference. There was little mention of treatment and no mention of surgery at that time, and research needs were outlined. The third consensus conference occurred in 1991, and in my estimation was the conference that had the greatest impact on healthcare and bariatric surgery. This panel was comprised of 8 panel members, and presentations were made by all the leadership of the then ASBS, and it was at that conference that the construct where in bariatric surgery was judged to be an appropriate consideration for all people with BMI greater than 40 or BMI greater than 35 with a comorbidity. Remarkably, this construct has held up for the 22 years since this recommendation was made by the consensus conference of 1991. As a consensus conference, it wasn't actually an official statement of the NIH, but that came in 1998, when the NIH convened a panel to construct the first national guidelines for the treatment of obesity. That panel, which did not include a surgeon, concluded that weight loss should be about 1 to 2 pounds per week for a period of 6 months, and then a weight maintenance program should be initiated. When we challenged the insurance companies as to, well, where do they get this idea that there should be a 6-month waiting time or interval of preoperative diet treatment before they will authorize surgery, this is what they quote. It doesn't specifically address the issue of preparation for surgery, but it does state that intensive treatment should be done for 6 months and then a maintenance program initiated. Regarding surgery, this document stated that weight loss surgery is an option for carefully selected patients with clinically severe obesity, again, BMI greater than 40, 35 with comorbid conditions, when less invasive methods of weight loss have failed, and the patients are at high risk for obesity-associated morbidity and mortality, which is basically all of the people who have a BMI greater than 40. So in essence, they restated the conclusions of the 1991. As Jaime indicated, in 2008, the NIH, the NHLBI, and NIDDK institutes convened a panel for the purpose of updating the 1998 guidelines, because it had been 10 years, and it was obviously time to do so. This activity was a component of the cardiovascular risk assessment program of the NIH and included panels to separately examine cardiovascular risk in relation to the treatment of hypertension and dyslipidemia. As indicated, it took 5 years until Tuesday of this week for this guideline document to be completed and released. It involved a literature search, assessment of the literature, selection of papers that constitute the evidence base, summary tables derived from the evidence base, and then recommendations based on that. So the key question is, well, what is the evidence base? Who decides what is included in the evidence base? And what are the criteria for basing such recommendations and treatment decisions? Now, many of us would say, well, the literature in its totality, all that we know from our experience from published and unpublished data, as well as the totality of the literature as we know it, is the evidence base. The alternate view, which for better or worse is taking hold, is that the evidence base is not, in fact, based on the totality of the literature, but is based on strict criteria for systematic review. Now, in response to the observation that the number of clinical guidelines which were registered formally in one of two registries by 2008 exceeded 6,000. So clinical guidelines, while potentially useful to healthcare providers as well as the public at large, certainly have a role. But the problem was apparent that anyone who wanted to issue a guideline on any topic they chose could do so and have it registered. So there was an issue as to what is the relevance, appropriateness, rigor of these guidelines. So Congress, in fact, in 2008, instructed the Institute of Medicine to develop standards for the conduct of systematic reviews and the development of clinical practice guidelines. The Institute of Medicine was established in 1970 by the National Academy of Sciences to secure the services of eminent members of the appropriate professions in examining public policy matters, and is regarded as one of the top honors that can be bestowed on anyone who is in academic healthcare, public policy, government, and the like. And the total membership by invitation, it's quite an exclusive club, although there are about 1,600 total members, some of them directly involved in healthcare, many not. So they came out with their statement in 2011, two monographs, Clinical Practice Guidelines We Can Trust. Because they're the IOM, never mind the content, it was immediately declared to be the gold standard on how guidelines and systematic reviews should be done. This is some of the standards that are listed in their monograph. The systematic review, that is the review and identification of the papers that will constitute the evidence base, is done by an expert team. There's user and stakeholder input, but the actual search and grading of the papers is not done by the panel members, but rather by methodologists who examine the study design, the retention rates, and other technical aspects of the paper. They are not familiar with the subject at hand. Another major point is that bias must be managed. There is a widespread perception that virtually all literature, all healthcare, everything that happens is hopelessly impaired by bias. And so every effort must be made to manage bias, protect independence at the same time, articulate the questions, and there must be transparency. With regard to the rules for construct of clinical practice guidelines, again, there must be transparency, manage conflict of interest. Now, that's a pretty complicated subject that nobody quite knows how to manage, because they say, well, the panel members should not have a stake in what is decided with the guidelines. That is, if the guidelines recommend surgery, then there should be no surgeon. If they recommend diet treatment, then there should be no one who does that. It turns out, however, that there is no such thing as an expert panel that has no involvement in the activity in question. So other methods are used to try to manage a conflict of interest, and the guidelines do detail how that was done. It is crucial, given this problem of the conflict of interest, that the panel be multidisciplinary. Any guideline that is issued by a single specialty organization is to be promptly disregarded and is considered hopelessly biased. Patient advocates should be brought into the process. Exactly how that works or is done remains to be determined. The guidelines should be based on the systematic review of the questions that are asked. Again, the systematic review is done with those rules that I mentioned, including that the selection of the papers is not done by the expert panel. Then the strength of the recommendations is graded according to specific scales. External review is done of the document before it is released, and there should be timely update of all guidelines, obviously. So the initial search criteria that were presented to our panel included limitation of the citations to randomized clinical trials published between 1998 and 2009. Meta-analyses could be considered only if they were meta-analyses of RCTs. The follow-up criteria for initial review, 65% at 2 years minimum, but then the quality of the papers was separately reviewed again by these methodologists, not by the panel, who classified the papers as good or fair, and if they weren't good or fair, they were excluded. And to be good or fair, they had to have 80% follow-up at the end of the study, or if a completers analysis is done, which is, what that means is that you report the data on the folks who were still in the trial, and you have their data at the end of the study, whether it's 2 years or 10 years or whenever. So if there have been dropouts and you're only reporting the data on those who are still in the trial, then you needed 90% retention for that trial. So the search was done. 2,300 citations were identified. The number of citations that met the criteria regarding the efficacy of bariatric surgery was 3. One of which was severely flawed when I examined it because the authors didn't really understand the difference between a BPD and a gastric bypass. And all the papers of the SOS and Adams and every other of the 2,300 was excluded for various reasons. Well, this occurred in the medical side of this review as well. So the panel, in essence, rejected the search, which is why it took 5 years, and said we cannot write guidelines with this evidence base. That will come out with wrong answers, wrong recommendations. We just not going to do that. So we then entered into a negotiation and compromise to come up with new criteria for the search. And for surgery, it was agreed that we would divide the search into 3 categories: the efficacy, the predictors of outcomes, and identification of complications. I was also given the opportunity to identify papers that were missed and submit those because the searchers clearly missed some papers. My favorite was they missed the labs paper on complications that appeared in the New England Journal of Medicine, not exactly an obscure publication. There was no explanation as to how that happened. And I also had the right to appeal excluded papers, and they were required to give me a reason why they had excluded. I appealed more than 100, and some of those exclusions were reversed, most were not. Furthermore, the criteria were revised for inclusion of non-randomized controlled trials. What that meant was that now the Swedish obese subjects papers by study design could be considered because that is a matched cohort design with a control group as well matched as the subjects could be using the resources of the Swedish healthcare system. These investigators in Sweden in the early 80s had proposed an RCT, but the human subject protection mechanism in Sweden at the time refused. So that is the reason that it was not an RCT. The other criteria were the same with regard to the follow-up and so forth. Exclusions included before-after series, which is a great majority of the papers in bariatric surgery, cross-sectional studies where you examine the outcomes at a specific point in time, and the quality ratings were the same. Regarding predictors, this would mean predictors according to patient factors or according to interventions. The comparator group did not have to be a non-surgical comparator, but could be one intervention compared to another, as in one operation compared to another. In order to get buy-in, remember I'm the only surgeon at this group, we agreed that if it's not an RCT, we would insist on a number of 500 for the sample size, when it turned out that there weren't any such papers with follow-up over 10 years, or there were very few, just the SOS, and that pretty much let out all the papers on BPD and sleeve, that we would accept an N of 100 for those topics. Regarding complications, it's actually stated right in the IOM report that observational studies may be necessary and appropriate to fill gaps not met by RCTs. So when we hear that the IOM said that it's this RCT only rule for the evidence base, that is actually not correct. They recognize that observational studies under certain circumstances may be appropriate to comprise the evidence base. And complications are one example. If you limit your search to RCTs, because they're so difficult to do, they're all relatively small. And you can never define the prevalence of uncommon but serious complications if you have too small a sample size. So I was able to convince the panel that we needed to add comparator group not required. Before-after series are okay. If they have adequate follow-up and adequate power, then defining complications has nothing to do with comparing it to another procedure or medical treatment. And what follow-up was required in another compromise became a case-by-case matter because nobody really has criteria over what the follow-up expectation should be for a 10-year study. The medical trials where these come from are totally dominated by 2-year studies. So the result of all this was, about 3.5 years later, that I wound up with 44 papers that could now be used to constitute the evidence base. These are based on 29 studies because particularly the SOS had several papers from a single study. From that, 31 evidence statements were written. Examples of the evidence statements include that the weight loss following surgery is superior to non-surgical comparators. The comorbidity responses are generally favorable, and that surgery results in a total mortality improvement or decrease compared to no surgery. Goes on to say that the weight loss for gastric bypass is superior to that of adjustable gastric banding. We did not have enough evidence in these papers to make any statement regarding a difference in weight loss between BPD, gastric bypass, and sleeve, but we could observe that the diabetes improvements appeared to be best in BPD, intermediate gastric bypass, and least with adjustable banding. There was insufficient evidence regarding the complications of sleeve because of the criteria for the papers and the fact that the search ended in December 31, 2009. There's furthermore an evidence statement that there's insufficient evidence to justify any statement regarding what the duration or amount of weight loss prior to surgery requirement should be. So if our insurance colleagues want to quote the guidelines to say that there should be a 6-month trial prior to undergoing surgery, it could have been in the past, it could have been at Weight Watchers. There is no evidence to say that a 6-month trial prior to surgery is justified. We also wrote what the research needs are based on the limitations of the search. What's key and what's been a focus of this meeting is the durability of the benefits. The benefits of bariatric surgery are pretty well defined for 2 to 3 years. We heard from the SOS about 10 year and beyond follow-up, and the durability of the weight loss and the comorbidity responses, which may not be the same, are of critical importance. And we had no literature at all on how often do complications actually occur beyond 2 to 3 years. So that's another research need. Finally, a research need is to identify the best candidates for surgery and the specific procedures that might be matched to which candidate. And certainly variability of the response to surgery is the focus of the labs paper, which will be presented this afternoon and discussed further at the JAMA session later this afternoon. Obesity is a heterogeneous disease, and the response to a single intervention, that is gastric bypass, is highly variable. And if we could identify which patients are the best candidates and for lesser procedures and all, we would have much better results in general. Recommendations in the medical component of the guidelines are that 3 to 5% weight loss gives meaningful benefits, but greater weight loss leads to greater benefit. Seems pretty obvious, but it's good to have evidence to that effect. There is no ideal diet for weight loss. The recommendation regarding surgery is as follows. This is directed to primary care providers and their teams. Advise your patients with BMI greater than 35 and a comorbidity or greater than 40 that bariatric surgery may be an appropriate option to improve health, and offer referral to an experienced bariatric surgeon for consultation and evaluation. Now let me just say that again, because this is the key to this document. Advise the patients who have a severe obesity, they've had either recurrence of the obesity or they haven't lost weight, that they should refer that patient for surgical evaluation. That is not happening now. If these guidelines come to be practiced in the medical community, I believe this would be a game changer in the treatment of obesity and access to surgery. The document was basically done in January of this year. It underwent internal and external review by various folks at NIH and outside of NIH. Some of the reviewers wrote back and said, well, this document is favorable to surgery. That can't be right. To them, Sue Yanofsky and I, who were working together on this project intensely, wrote, it's the evidence, and we had no comment. We didn't comment further. In May, the NIH announced in about a 1-paragraph announcement that they were getting out of the NIH business, and that they would actually not be publishing these or the hypertension or dyslipidemia guidelines, but instead they were turning the whole project over to the American Heart Association and the American College of Cardiology. We were actually astounded by this announcement, and was pointed out that neither of these organizations has any particular expertise in the matter of obesity, whereupon the Obesity Society was invited to join the partnership to publish and release the guidelines. And so further reviews, we had to redo the ratings of the quality of the recommendations according to the American Heart criteria. This was all done, and the guidelines were released on Tuesday. Because the total document runs 700 pages, the executive summary is 70 pages, and they're published along with the guidelines on lipids and hypertension. It's going to take some time for the media, the public, and the medical community to sift through all this and see what's really in there. But I would encourage everyone to be very much aware of these recommendations, because they are important to what we do. Now, I'll just briefly comment on, does the story end there? And I submit that it does not. When the Affordable Care Act was passed, Secretary Sebelius was charged with coming up with, well, what is the essential health benefit? What should it be? And we all know that this is what has created a nightmare for President Obama as I speak. Secretary Sebelius didn't know what to do with that, so she turned it over to the IOM and said to the IOM, what should the essential health care benefit be? So the IOM had a hearing in Washington, D.C. On this matter with the help of Joe Naglowski and Ted Kyle from OAC and TOS. I managed to get a spot at this hearing and testified before the IOM and gave them a written report. I was congratulated by many for a scholarly presentation in comparison to some others that were done at that hearing. So here's what the IOM came out with in their report when it was all said and done. The first is that, in keeping with what's in the law, there's going to be a paradigm change in how Medicare functions. At the present time, if an additional treatment is identified that Medicare beneficiaries should receive, they do, and we just move up the date that the Medicare trust fund runs dry. That's changed by the new plan, which is the amount of money allocated to Medicare will be fixed, and if we don't meet those cost targets, then the list of exclusions to Medicare beneficiaries or rates of reimbursement, a combination, will be done to stay within the fixed amount of funding available. So that's where they come with this, that the EHB should be defined as a package that will fall under a predefined cost target rather than building a package and then finding out what it would cost. They basically said, well, we can't figure it out what the essential health benefit should be, but we do know that there will need to be exclusions. And they go on to list, for example, exclusions might be defined as specific services, such as a plan does not cover cosmetic surgery, bariatric surgery, infertility, and so on. There is no mention in the report of any need to treat obesity in any way, and instead we get this. In the same sentence with cosmetic surgery, infertility, and so forth. Not that those aren't important and they shouldn't be available to people, but all of us know that bariatric surgery is not in that league. So what about the Affordable Care Act and Medicare cost containment? Well, we're going to cover interventions that work, reject those that don't. Evidence-based treatment sounds good. Surgeons, in fact, have been doing evidence-based treatment for more than 100 years. If you go back and look at the early papers in surgery, they report outcomes of operations that have been done in order to inform us all as to whether those procedures should continue, be revised, or new ones invented. They also, to a very limited extent, funded comparative research. So what happens if we don't meet the cost containment plan regarding Medicare? Well, according to the law, then the Independent Payment Advisory Board, which answers to the administration, not to Congress, which is the present plan, it kicks in, and this board is charged with determining what additional exclusions should be invoked in the Medicare program. What is specified is that there cannot be a majority of clinicians on this board. What method they will use for their systematic review and making their determinations is not defined, but my experience for the last 5 years indicates to me that this methodology movement is likely to be applied. And whether they stick to RCTs or they have a process similar to the one that our panel rejected remains to be determined. But we do know that it's critical, even if frustrating, time-consuming, maddening as it is, it's crucial that we remain involved. If we don't, then we won't like what comes from it. So let me conclude by saying that the NIH has been and continues to be a crucial partner in the development of bariatric metabolic surgery. However, there are no more are there NIH guidelines. We've been quoting the NIH for 22 years, saying that the NIH statement is that we would do bariatric surgery for BMI greater than 40, greater than 35. Well, now it's the American Heart Association that we will have to quote. We can say that the NIH used to have a statement, but they don't anymore. There are a lot of questions that this raises. How will revisions be done? Who will do them? What method will be used? These societies, particularly TOS in the obesity area, and our own society does not have a pot of money just sitting there to fund these methodologists who do the search. You can imagine it's not cheap to hire a group of folks who review and critically analyze 2,300 papers in surgery alone, and that's just one of the 5 questions that the panel examined. So there's great uncertainty as to what the process should really be, how it works out, how it's going to be done, how it's going to be funded, who's going to be at the table, and how do we prevent these panels from coming up with the wrong answer. Because I can assure you that that could have happened, and if the panelists weren't there, it would have happened. Next, evidence-based, the most rigorous search ever done in bariatric surgery provides strong support for bariatric surgery, in fact. And that is how we got a recommendation that all of patients who have severe obesity and are struggling with it should be referred to a bariatric surgeon. And we need to take that away from this whole process. As I say, we need to be involved in ongoing research and its translation into policy, even though it's time-consuming, frustrating, and, as I've made clear, not always successful, as with the IOM. But still, we have to hang in there. My final comment is that the root problem, as I said 2.5 years ago in my presidential address, is obesity bias. We see it from the highest levels of academia, as I've demonstrated with the IOM, to the everyday people. Bias leads to discrimination. Discrimination is always harmful. We need to be ever alert for identification and response when we encounter a bias. Again, my honor and pleasure to deliver the Mason Lecture, and thank you very much.
Thank you very much, Bruce. We, on behalf of the ASMBS, we wanted to really thank you for all the work that you did on this. I know that you, like Robin, keep calling you, you were our Don Quixote person, just working alone with this group of researchers, and really the only one that was trying to defend the inclusion of any bariatric surgery evidence that we had. So we wanted to give you a plaque for your presentation today in the Mason Lecture. Thank you.
Thank you very much.
Thank you.
My pleasure.
I think I